Hello, good evening. Welcome everyone to my IVF Fences and the European Fertility Society. We are back with another topic when we are back with another doctor. Dr. Khrystyna Mokra is with us today. Hello, Dr. Khrystyna. Glad to have you here. This is your first webinar with us, so I'm happy that you joined our experts, our doctors who we are inviting every week. So I'm glad that you are joining today. How are you feeling? Hope everything is good and you are ready to educate us a bit.
Yeah, I'm fully ready.
Perfect. Thank you so much for joining us today. And let me just briefly remind everyone that we will start with Dr. Khrystyna's presentation. And today's topic is definitely an interesting topic. And I don't think we've covered this before in the past. So I'm glad that we are going to actually dive deep into the AMH, FSH, and LH. So we will talk about fertility markers, and Dr. Khrystyna will be definitely happy to explain everything for you. But as always, you know, we will also have time for your questions. So please remember to put those in the chat. Dr. Khrystyna will answer them right after her presentation. This is recorded. Remember, it's all anonymous, so I can only encourage you to just put the questions and get as many answers as possible. We have around 30 minutes for the questions and around 30 minutes for the presentation. So feel free to put your questions in the chat during the presentation or afterwards. And I think that we can start with the presentation. Before we do that, let me just remind everyone, Dr. Khrystyna Mokra, she is the gynecologist and reproductive specialist at Alternatyva Clinic, located in Ukraine, in Lviv right now. So thank you so much for joining. And I think we can start. Ready to start with the presentation? Perfect. Thank you so much. And I can see someone typed you are coming from London. I'm sure there are other people from other countries. So thank you so much, everyone, for joining. And let's begin our presentation now.
Let's discuss these hormones, AMH, FSH, and LH. These hormones are very important in reproductive medicine because they are offering to ovarian reserve, follicular development, and ovulation timing. So by understanding their individual roles and interplay, we can better assess and manage fertility challenge in our patients. So let's start from introduction of these hormones. Fertility depends on the precise coordinator of hormones that regulate ovarian function of the menstrual cycle. Among these, AMH, FSH, and LH stand out as key markers. So again, they are very important. Each provide unique piece of the puzzle of our hormonal system, and it comes to understanding reproductive health. So AMH give us understanding of the ovarian reserve, helping us to predict how many eggs patients has left. FSH drives follicles recruitment and growth, and LH is the trigger of ovulation, and it gives us understanding will we have mature egg or not in this cycle. Today we will explore how these hormones fluctuate during the cycle, their clinical applications, and how they can affect our system, and how they can affect our treatment. So let's continue. Okay, so let's start from understanding about all these hormones. AMH is secreted by granulosa cells in ovarian follicles. So we have antral follicles, and each of these follicles can produce AMH hormone. AMH is a marker of ovarian reserve, and this hormone we can check during the menstrual cycle. It not depends to day of the cycle. So it's very good for us, as patients can come to us on any day of the cycle, and we can check AMH and think what we can do next. FSH produced by pituitary gland SSLH, next our hormone, and FSH central role is in follicle recruitment. It plays a central role to to choose one follicle that will be dominant and will ovulate. And of course, LH is also secreted by this gland, we already discussed it, and this is trigger of ovulation. Also, LH is supporting corpus luteum during the luteal phase, which is also very important. Okay, so we can now discuss more our hormones. Let's start from AMH. As I said, AMH is first step what we are checking with patients, and it's individual marker for ovarian reserve. It is produced by small ovaries, as we already discussed. It depends on woman age. At next slide, I will show you how it depends on woman age. And as I already said, IMH remains stable through the menstrual cycle, so it's great for us as IVF specialist. For us, IMH can show us such problems as PCOS or diminished ovarian reserve. So as we see high level or low level, we can already know what we should predict from these patients and what we can say this patient should do at the future. On this slide, you can see how AMH level changed during the woman's life. Please don't be scared, because I know in many countries AMH level have different units. Here you can see in nanogram of milliliter, but in many countries we can see picomole. So it's not a problem for us. We usually converting these numbers, but when we spoke about nanograms, the levels are like this. So younger women have higher level of IMH, but now we have very big problem when we see young women 20, 30 years and we see small IMH. So I think we should discuss this standard levels of IMH because it's changing now. So let's go into next hormone, FSH hormone and its role. So FSH hormone is the central of follicle recruitment and growth. During the early follicle phase of menstrual cycle, FSH levels rise to stimulate the growth of the ovarian follicles. Then one dominant follicle emerges and it will be ready to ovulate when it will have size for ovulation. FSH level peak just before ovulation and then decline in the luteal phase, but this is only in ideal menstrual cycle. I have many cases of women when we have after one ovulation, again FSH is growing and we have another growing of dominant follicle in luteal phase. So persistently elevating FSH level, especially on day 2 and 3 of the cycle, can be sign for us as IVF specialist for menopause or reduced ovarian reserve. And monitoring of FSH level can show us ovarian function, and during the ovarian induction or controlled ovarian stimulation, it can show us how fertility treatment will go. So it's very important to us. Let's go next. LH hormone or luteinization hormone plays critical role on the second half of the follicular phase. So when we are going to ovulation. It's very low during the most of the cycle, and it surged dramatically around 14 days when we spoke about ideal 28-day cycle. The LH surge triggering ovulation, and it causes a dominant follicle to rupture and release a mature egg. Following ovulation, also LH support corpus luteum, and then progesterone takes this role for it, but on ovulation LH do this. Tracking the LH curve can show us in natural cycle when we expect ovulation. So when we are going in treatment like UE, or when we are monitoring natural cycle of patients, it's very important to us when we can do some procedures, or when we can recommend patients to live active sexual life. So let's continue, and our next slide will be interplay of AMH, FSH, and LH. These three hormones, we should understand that they don't act in isolation. So we should understand that all hormones in woman body are working together. And especially AMH, FSH, and LH, they are working together in regulated system. AMH indirectly regulate FSH level, preparing one for by limiting the recruitment of excess follicles. FSH stimulates the growth of follicles, preparing one for ovulation, and LH doing for us the ovulation. This balance can give us one mature egg when we speak about natural cycle, and this give us optimizing chance of conception while we spoke about ovarian function. Okay, 1 second, I will drink water. In clinical practice, these hormones serve distinct but completely purpose. AMH helps assess ovarian reserve, make it a key tool in fertility preservation and guiding stimulation protocol in IVF. So as I said at the beginning, AMH is first marker that we are doing before the IVF. FSH provides insight into ovarian again and response to stimulation, and LH is essential for monitoring ovulation in natural cycle, UE, or when we are monitoring cycle if we have ovulation at all. Together, these hormones provide a completely picture of a woman hormonal panel, and we can see if it's working correct or we should do something to do it correct. Okay. When we spoke about abnormalities of these hormones, let's start from high FSH and low AMH. These markers can show us about diminished ovarian reserve or menopause. High LH relative to FSH is characteristic for PCOS, very common problem now. Of course, we see this woman every day. And in case if level of LH and FSH is suppressed, we can speak about hypothalamic hypomenorrhea when we don't see any hormones, and ovulation cannot happen because of this. Hormone is not going. Okay, and now I think we should discuss when we have low or high level of each hormone, what we can see, because if we understand abnormalities, we understand what to do with it. So let's start with LH. When we have elevated LH, it's first signal us to think about polycystic ovary syndrome like PCOS. Of course, you may know that we cannot give the patient diagnose PCOS only when we see hormonal panel. We should have also ultrasound picture like multiple ovaries, or we can speak about her cycle. Usually the cycle is irregular and we don't see ovulation. So these patients usually have anovulation, infertility, they have irregular cycle, and the main problem is that they don't have ovulation. And usually we just need to stimulate ovulation, so suppress the level of LH, but it's not so easy as you can think. Okay, let's go. When we have suppressed LH and FSH, I had such patient last month, and she thinks that she thought that she had some problems with thyroid gland, but we found that this is not thyroid gland. We found that this is hypothalamic amenorrhea or central hypogonadism. So her hypothalamus reduced secretion of hormones, and she didn't had FSH and LH at all, and she didn't had cycle and ovulation. We gave her hormonal replacement therapy, and her cycle started again, because in her case it was because of very big stress, and she lost I think 10 kilograms at 1 and 2 months. So this is very big. This is very big problem. So let's go on our next slide. Our next slide is elevated FSH. When we see elevated FSH, when we see menopause, so elevated FSH can be when we see on panel in women who are already in menopause or diminished ovarian reserve. This is a problem when patients have very small number of antral follicles, and it can happen also in young age or also in older age, so we cannot control it now. At past we saw this problem only in older patients, but now it's usually a young problem. So let's continue. Low AMH, it's the same problem. We can see it on menopause after 35 years, but also it's not depend to age now, as we can see, and diminished ovarian reserve. And when we see low AMH, we know that IVF stimulation will be the best treatment for us, but we should give high dosage of FSH and LH to stimulate these ovaries to work them. Okay, high AMH, as we already spoke, this can be PCOS syndrome, but also I should say that high AMH is not always about PCOS. I also see many patients with high AMH with multifollicular ovaries, but they have regular cycles, they have ovulation. So now we can say that high AMH can be also in PCOS women, and also it can be in multiple follicle ovaries. So when I doing ultrasound, I just writing this diagnosis. Okay, and now, so how hormones going across the cycle. In normal menstrual cycle, FSH rise in the early follicle phase to recruit follicles. LH remains low until the mid-cycle and surge during trigger ovulation. AMH is regular during all the cycle, and also here I should say that we also have estrogen and progesterone. This is, of course, we're not speaking about them right now, but they regulate also first and second phase of the cycle, and they are very important. So understanding these patterns help us identify abnormalities like on ovulation or problems on luteal phase and help our patients. And also I prepared to you two cases that I had last week, and they can show us how we're working with patients and how these hormones helping us. So first patient, 38 years old woman. She has low AMH and elevated FSH, and she had diagnostic like DOR, and in such case we gave her high dose stimulation with FSH to stimulate her ovaries, and in her situation we should cryopreservate this oocyte that we will get on the punction. And case second, 25 years old woman with irregular cycle, high LH to FSH, high IMH, and we can give her diagnosis PCOS. She want to be pregnant, so we think about induction her ovulation with medication like letrozole or something like that. We are still thinking and doing diagnostic to her. These two examples show us how these hormones can help us. Oh, and it's already 25 minutes, so going to conclusions. To summarize, AMH, FSH, and LH provide valuable insight into ovarian reserve, follicular development, and ovarian function at all. Their role are very important for us, and their careful interpretation by doctors, by IVF specialists or gynecologist is essential for optimizing fertility care. Hormonal testing should be done to every patient that are starting IVF treatment or they are thinking about their fertility plans and future. They should be discussed with their gynecologist, and this provide us personalized treatment for every patient and with every problem that we can see. And yeah, this is last slide. Thank you for this. Sorry, this was my first webinar, but I hope this was interesting information for you and you understand now role of these key hormones. Now you better understand maybe your personal situation, and if you have question, I will be happy to answer.
Excellent. Thank you so much, Dr. Khrystyna, for answering. You will answer some of the questions. They are here, but of course, for your presentation explaining the function, the hormones, AMH, FSH, LH. It's very important to understand this, and I've seen some interesting and intriguing questions in the chat already. So thank you so much, everyone, for putting those in the chat now. We will take care of those for you. And let me just start with the first one.
Okay.
That we've got here. There are two questions, okay? Yeah, more questions are coming up. So we are starting our Q&A. So if you have anything you wish to ask, do it now.
Okay.
So I will show you there are two questions. So let me show you this. So how big differences can AMH have based on the lab that was checked? How quickly does AMH fall? And I went from 4.66 to 1.44 in just 1.5 years. Let's take a look at those two questions.
Yeah, so how big difference can AMH based on the lab? So I have a big experience when we had some experiments with our patients. We did AMH in different labs. It was 4 labs and 5 patients, and always AMH was I will show you example. In one lab it was 2.4, in second lab it was 2.44, 54, so usually it's the same number. It cannot change in every lab. It can change because one lab is doing in nanograms, one lab is doing in picomoles, but usually it's the same numbers. And the second question, how quickly does AMH fall? Yes, we have such problem, and now I see the patients that have fall not in 1.5 year. I see the falling in two months. So now I have one patient in treatment. She had on July AMH level 2.5, and now we have 0.44, so it's very big problem, and she's very young. So yes, now we have problems that AMH level is falling. Many IVF specialists trying to find why this is happening. Of course, this is because of everything what is happening around us. Also, this is genetic. Now we think that the main role is genetic.
Okay, thank you so much indeed for those two questions, Victoria, and of course, thanks for answering them. And this is a question, short one. So, can AMH rise? I'm sure you've got lots of questions in regards to this.
Yes, there are many experimental treatments like PRP of ovarians, some cell therapy. I had patients with all of this treatment, and I saw only better quality of oocyte, but not a higher number of oocytes. AMH number cannot rise, only the quality of oocytes.
Okay, and just because you've mentioned PRP, for example, so you do offer PRP at your clinic as well. It's available.
I'm doing, but not often. Because
Okay, still experimental, right?
yes, this is very experimental treatment.
It's still nothing. It's not like a standard procedure, yeah. So I guess it's only for.
I more believe in PRP in endometrium because we see the results.
Yeah. Okay. Of course, we've done some webinars on PRP, so we know that it's still experimental. So you need to be careful when concerning this kind of treatment as well. Okay. Thank you. Crystal clear. Could you take a look? So what is the conversion from nanograms to picomole? My AMH is 2.1 picomole. I'm 44 or 45.
So I should open the calculator, but
Sure.
from my but I think it's around 0.3.
Okay. That was 2.1 picomoles. Yeah.
So I will open. Give me 1 second.
Yeah, you can. Let's double check it. So we will give you a direct answer. Yes, yeah, and in the meantime, please remember to include the picomoles or nanograms. It's quite a difference. So whenever you are adding your age, it will be helpful if you can provide that.
So this is 0.3, as I said.
3, just like you said. Okay. And let's see. Marlene has another question here. So I'm 49. AMH is 0.2. Is there any chance for IVF or having a baby without an egg donation? I believe here, yeah.
Yes, of course we can do it, but it will be high. It will be protocol with high dosage, and it can be 2 or 3 protocols to calculate to how many oocytes. I think 6 or 5. It will be enough, and I think yes, of course. I had patient. I'm going to examples.
But that's good. That's what we want.
I had patient 47 years old, 47 years old with AMH 0.24, and we did 2 stimulations for her, and now she is carrying her own baby.
Okay, so it's possible.
Yes,
and just while we are talking about it, of course, is there like an age limit for at the clinic? Because I know you might have your own age limit. It's a question that usually
Yes, our age
comes up a lot.
limit. Yes, our age limit is 53 years. Is for going IVF with carrying baby by yourself. We are not speaking about surrogacy now.
Of course, yeah. Okay, that makes sense. Thank you for the clarification. So 53,
Yes.
just if anyone is wondering about it. Okay, there are some details here, so I will show you. Karen would like to know, so is Pergoveris 375 units only good for 39-year-old? AMH 6.20, picomoles, BMI 30, 31, tried menopause, overlap, gonal F, mix in past 450 units, trying to improve number of follicles. Anything you can advise here?
Okay, so usually when I'm starting the protocol, I'm not looking only on IMH, I'm looking on ovarians because usually we are looking on IMH, but we are checking ovarians and we see good picture. And sometimes I'm giving protocol to patients before the stimulation. I said, I think we will start with this treatment, but then I see ultrasound or before the beginning, and I say no, we are changing protocol. I think better will be next treatment. In your specific situation, maybe I will start. I think I only depends to AMH and BMI. I think I will start with you with gonal F 300 and maybe add Pergoveris 150. I think like that, but we should check because when I see such AMH and such BMI, I'm trying to go to protocol with antagonist and trying maybe long protocol. So this is also can affect the number of follicles. Also, in these cases, the grade will be to start Japan protocol. You know, when we're doing one punction and we start next stimulation, it usually give us excellent result.
Okay, sounds good. Thank you. I hope that helped you. And I will go to the follow-up from Marlene, who there was a question. Her question was here. So she is 49, AMH 0.2, and she would simply like to know. I think we covered this, but basically she would like to ask if would you do the treatment? Yeah, in Lviv.
Yes, yes, of course,
Okay.
we will be happy.
Sure. So yeah, remember that of course you can get in touch with Dr. Khrystyna directly, or I will be happy to forward your message. It's always possible, so we can do that. I hope that again helped you and answered your question. And in the meantime, of course, we have more questions coming up. So let me go to the next one from Roxana. My AMH is 2.65 nanograms, FSH 5.6 units, and 6 oocytes in an IVF cycle. Is this a good result? 35. H is 35.
According to AMH level, I think we can get more oocytes, but again, this is I don't see specific stimulation because many details depend on the trigger of ovulation. When we gave decaptil or differylin, of course, the number of oocyte can be not as we expected, but when we gave HCG ovulation trigger, the number of oocytes will be bigger. But again, it depends to how many follicles we have, hyperstimulation, of course. So we should think about everything. But 6 oocytes in age 35 is good result.
Okay, thank you for the reassurance here. Okay, Roxana actually added some details. I think I can show you this. Just give me a second. I need to scroll down. She added 225 Pergoveris and Ovitrel trigger.
Yes, this is good result, of course.
Okay. All right. Thanks for the confirmation once again. And, if you have any follow-ups, go ahead, type those in. Victoria would like to ask, can IVF reduce AMH more than a regular cycle?
No. Now, this is myth. I will explain why. During the cycle, normal cycle, for example, we have in ovaries 8 antral follicles. From these 8 antral follicles, one starting to grow, and one will be dominant follicle and one will be ovulated. And this last 7, they will not go to the next cycle. They will like disappear in this cycle. So when we are stimulating follicles in IVF treatment, in stimulation protocol, we are stimulating all these 8 follicles. So we just give hormones to these follicles that will disappear in the one specific cycle. So we are not reducing AMH level in IVF treatment. We're just helping follicles, all follicles that we can catch in the cycle to grow.
Okay, again, thank you so much for your advice here. And again, Gabriela has another question. Let me show you some details. I am 43, AMH is 0.5, FSH, sorry, 11. Can I raise my AMH level, right? And low FSH. What can I do to get more follicles? Now I have 4, 5 per month. Anything you can advise here?
4, 5 months on 43 years is very good results, and FSH 11 is absolutely normal. So it's absolutely normal FSH and AMH for your age. You can undergo IVF protocol. Maybe for you will be great to go Japan protocol to catch many follicles. So I will explain how it's going Japan protocol. We are stimulation patient. We do the we doing trigger ovulations, and we do the OPU, so aspiration of oocytes, and then we start another cycle. And usually this another stimulation cycle is more effective than this first one, and usually it's working in patients who have 5, 6 oocytes and less, and next cycle we get more.
Okay, again, brilliant. Thank you so much for yet another answer to the question. As you can see, Dr. Khrystyna, lots of questions, and it's good. Well, that's why we are here. So thanks a lot, everyone, for spending this evening with us as well. So let's see. I have another question from Karen. I've heard of I heard a mix of 2.21. Okay, LH and FSH is the best option for stimulation medication. Any thoughts on this?
We cannot tell best option for stimulation medication, because stimulation protocol, stimulation medication is very individual thing. And for some, I usually go with protocols that include FSH and LH, and yes, it's working. But some patients, they when we gave them LH, we see that follicles are not growing. We take from protocol LH, and follicles are growing. So protocol is very individual thing. We cannot say that this is perfect protocol and we can go with it. We should look at, if we have a previous stimulation, great, we will analyze it. If we have hormonal panel, okay, we will go with it. Also, we will do hormonal checks during the stimulation, and if we will need to give also LH to FSH, of course we will give it. I had stimulation when I gave only LH, and we had all perfect results. So it depends to each patient.
Yeah, it's always about personalizing treatments, right? Exactly.
Yeah,
every patient is different. It's always something that, of course, we need to repeat because, of course, we've done many webinars. So I know that it's something that is repeating, and we need to remember that, of course. Thank you so much. Okay, let's have a look. We have some details here as well again. So is it true that the AMH level is influenced by taking contraceptive pills? A patient had fluctuations during the treatment period. There was a decline. Then after stopping, the level returned to its value a few months later. And thanks for the presentation.
Thank you, thank you. Now, also I have on my in clinic I have many patients during OCP. When I recommend OCP pills, how it will affect my AMH level. I don't know why, but patients think that when they are taking AMH pills, sorry, ACP pills, AMH is staying on the same position when they started OCP pills, but this is not true. Let's go back to the question. If IVF treatment reduce AMH level. So when we are taking OCP pills, we just don't have ovulation, but the menstrual cycle is going because we have menstruation, we have hormones, but they are suppressed, but we have them. So these 8 follicles just they are not growing, but they again disappear on this period. So we are not taking OCP pills to keep our IMH. We are taking OCP pills because of contraception, because of treatment, but not to keep IMH in the same level.
Thank you so much for the clarification. It's really important because, of course, there are lots of things that are not really clear for everyone, and I'm glad that we are discussing this, and it's important to mention that as well. And there is still no miracle, I would say, even medicine, right, for this.
Unfortunately.
This is the truth. Yeah. Thank you.
If we had
Let's
some
have a look.
miracle, we will do it.
Of course, no question about it, for sure. Thank you so much. And Gabriela has another question here. 43, AMH 0.5, FSH 11, 1 IVF did not implant. Can I get 1 euploid egg? I have 4 or 5 follicles. Anything you can advise here?
Yes, of course. After 35 years old, it's for us challenge to get not only oocytes, to get euploid embryo, but it depends to all the team works. Why I say this? Because after I can do great stimulation, but after I took the oocytes, I give them to the lab, and here embryologists start their work, and when we have 1000%, 100% results, so we get 6 oocytes from 6 follicles and six and next we get 6 embryos. Of course, we have better chances to get from these 6 embryos 1 euploid. Of course, we cannot guarantee this, but this is like we should try. We should try one stimulation. Second stimulation, third stimulation, and we will get this euploid embryo. I had cases when we had 5 stimulation, and only after 5 stimulation we get this 1 euploid embryo, but we got it.
So it's possible, sometimes just requires more times.
Yes, of course, but we should think, we
yeah?
should change, we should add something, we should discuss with embryologist, we should discuss with colleagues what we can change with in stimulation protocol. Should we add calcium to sperm or eggs to improve their quality during their growing? So it's not only
There are
about
ways.
yes, yeah.
Okay, thank you so much indeed again. And there's, as you said, this is always possible, so you just need to change things sometimes, and it may not work on the first time, but it's still possible. Thank you. That's always encouraging, I'm sure. Okay, next question. 37, AMH 0.5, FSH 8.9, IVF mini done 3 times. You want euploid embryo, we want banking. Would you suggest duostim?
Yes, I think yes, but all duostim is also we think about duostim during first stimulation. When we see that we see antral follicles on the ultrasound, and we see that we can do this duostimulation after the aspiration, of course we recommend this. So in your case, if we can see these antral follicles and we can think about their stimulation, of course this can be your variant.
Okay, great. Thank you so much again. And there are more questions coming up. Next one is quite a detailed question. Let me show you. So we have done 10 egg collections over the last 4 years, but now with reduced AMH 2.1 picomole with high dose stims like Mayofert 300 double triggers. My last cycle in October, I had 5 eggs, which was the best I've made in 2 years. We had ovarian PRP. 5 months before, we managed to get one blastocyst for AB, which was untested, and we transferred. It was 11th transfer, but sadly there was no implantation. I have tried long protocol 4 years ago, but no good response for me. Any other suggestions in this case?
I'm reading again.
Sure. Lots of details. Take your
Yes,
time.
so first of all, I think you should have break. I always said that we should have some break to think, and I think you should try again long protocol, but maybe not classic long protocol when we give the pot injection. Maybe a protocol with 0.1 decapeptyl or differalin. It can increase our chances. I think long protocol will work for you, and of course, testing of embryos will be very important because when again example, I had patient with 2 embryos. One embryo was perfect for AA, as I remember, and the second embryo was 3BC. And I asked, and embryologist said me, we will not test this 3BC. I said, please test it because we need to have employed embryo. So I was surprised because this 4AB was aneuploid, this 3BC was euploid. So you should test it because not only quality show us everything about embryo.
Okay, so I guess that can happen. So you would never, I guess you would not expect that the lower grade embryo is actually euploid and while the other one is not. So thank you so much. That's also interesting. So what stimulation is good for after 43 years old? Mini IVF? This is the question from Gabriela.
I don't think mini IVF. I'm usually not going mini IVF, but again, it's very individual thing. One time I had patients that had no reaction with mini IVF. We started with high dosage. It was also older patients after 45 years old. We started with high FSH dosage, and it was very successful. And I had many IVF with mini IVF with patient 30 years girl years old, and it was successful. So again, it depends to your individual protocol, your hormonal level, and ultrasound picture.
Sure. Thank you so much once again for your explanation to this question. And again, let's have a look. This is the question that also is definitely something that we hear and receive a lot. So do you have any suggestions for improving the quality of the oocytes?
Yeah, in my practice, I always giving patients myoinositol. So this is very good. This is very good medication to improve oocyte quality. I have good result on it. Also, when we see the bad oocyte quality after the stimulation and after the aspiration, we can speak with embryologist, and during in lab we can give calcium or some yes, usually is calcium to improve quality of oocytes, and it also working. I not believe in PRP of ovaries, as I already said, in cell therapy of ovaries, because it's usually I don't see this result.
At least you don't have evidence to prove that it's actually working, right?
Yes,
Because
but this is only
this
my
is
practice, so I cannot from my practice. So the best way is to take supplements the doctor provide to you, healthy lifestyle, and it can be also done in lab by calcium, adding calcium or something else.
All right. Thank you. Crystal clear. Two questions are left, of course, and we will be finishing. So if you have anything else, go ahead. We still have a few minutes, so go ahead, take those in. And the question is, does adenomyosis, endometriosis affect hormones?
Yeah, of course. Of course, it's affect hormones because this diseases hormones are affecting these diseases, and this disease can affect ovaries, for example, and ovaries are producing hormones. So when we see endometrial cyst, especially big cyst, when we see ultrasound and we don't see ovarian, we see only the cyst. Of course, it can affect AMH level, it can affect FSH levels. This woman can get menopause earlier than another woman. So yes, of course, this diseases are very related to hormones, and hormones are very related to these diseases.
Okay, again, thanks a lot. So this is in regards to our previous question. So that means that testing the embryo, this is the best way to have a successful IVF. Can you
Not
clarify it?
always. Not always. We always say that embryo is 50% and endometrium is also 50%. So not always testing of the embryo is way to improve the IVF success. Of course, if we have 1 second, sorry. Of course, if we have conditions like previous unsuccessful embryo transfer, previous miscarriages, age after 35, genetic diseases in family, of course IVF will be more successful. But if we have problems like male infertility, or this is PCOS or low AMH, it's not depend to embryo testing, because we can have one healthy embryo. I'm usually doing genetic testing only if we have for this some like we have diagnosis for this. But if we don't have, if I have young woman just with problem with male infertility, of course I'm not recommending to do this, because we can get healthy embryo without this. Again, individual.
Of course, this is usually how it works. Thank you for your explanation for this. And Belinda has one more question for you. I thought myoinositol was more for pros patients. I've heard some positive and negative opinions. What dosage do you recommend for non? I'm not sure here. Sorry, pros patients.
PCOS, yes, I think this PCOS.
Yep.
Yes, for PCOS patients. Why we are giving this for PCOS patients? Because it's help us regulate energy connection between the follicles. But because of this, it's also can help us regulate oocytes quality. So I see very good results when patients take the supplements, and we had good results on oocytes quality. So dosage is usually 200. It's okay. 200 is okay. For PCOS is for 500, but for not PCOS patients it's 200. Absolutely normal. And you don't this is only supplements. This is not usual medications that can affect your health, so you don't need to be scared about it.
Sure. Thank you so much. And I will go to the question from Belinda straight away. So do you think endometrial PRP is good? So I'm going to have another hysteroscopy next week in Greece, and maybe endometrial PRP if they think, yeah, just worried about cost and add-ons, which will actually be good. Anything you can advise here?
Yes, about endometrial PRP, I absolutely sure that it's great because I see very good results. I see in one cycle we see low thickness of endometrium, not good structure. We do PRP. On next cycle we see triple lining, good thickness. So I can see from my practice that yes, of course, yes.
Okay, so it's good to actually have a look at this and look into it, and it might be worth to actually go for it as well. Okay, thank you. If you need egg donation, will myo-inositol help you in any way?
If you need over donation with, sorry, I don't.
Will myo-inositol help you in any way?
If we have over donation now, and I'm going only with folic acid. So if we are not using your own oocytes, we don't need mines at all.
Okay, thank you. Just, for the clarification here. And Gabriela added right here that she has adenomyosis. So what protocol is good for egg implantation, right? So what protocol would you suggest in this case?
I think long protocol with depot injection is 3.75. It will evaluate your hormonal levels. We will control absolutely your hormonal level, and it will help to control adenomyosis as well.
Okay, brilliant. Thank you so much indeed. Possibly our final question. So thanks a lot. Lots of questions today, and I'm really happy to discuss this topic. As you can see, it's really important to talk about it. Brings lots of questions indeed. And so for egg quality, right? So is it okay? CoQ10, glutathione, NAD. I'm not sure here about that one. So
yeah, I know this.
Anything else? Okay.
Yes. So they are good, but I cannot tell for 100% that they will do super quality of oocyte. But yes, this harms that also you can take to improve your oocyte quality. This is supplement. They will not do nothing bad in normal dosage. It will recommend your doctor, and they can help. Yes.
All right. Perfect. Thank you so much. As I mentioned, it looks like that was our final question, but thank you everyone for very detailed questions. But of course, that's why we are here. We want to answer as many questions as possible. I believe it was useful from the comments. I can tell that it's been useful. As you can see, there are some comments here. Thank you for the webinar. Very insightful. Very good webinar. Amazing. Thank you so much. So thanks a lot for your comments here as well.
Thank you.
Dr. Khrystyna, it was lovely to have you. Any final thoughts before we finish for today?
Okay, I just want to thank everyone who supports Ukraine during this situation, and I want to tell you, don't be scared to come here. We will support you. We will help you. We are happy to work here because our work gives us. How to say power to live and to do what we want. So thank you everyone that you was here today. Thank you for your support and waiting for you to see and live.
Thank you so much indeed. And I just want to mention something that Dr. Khrystyna told me before we even start. Patients are coming to Ukraine. They are coming to Lviv to have treatment from different parts of Europe mostly, but they are coming. So of course it's definitely possible to simply be there. Thank you so much everyone, and it was great to have you. Of course we will be back with some more events, so stay tuned. There will be some more events with other experts from Alternatyva Clinic. We will have another event on the 12th of December. So you can sign up, go to our website, My Aviofences. You will find all information right there. And as you can see, the comments are coming in. Thank you for the comments here. Thank you for joining, and we will be back quite soon as well. Have a lovely evening. And
have a nice evening.
Finally, I want to add that if you wish to get in touch with Dr. Khrystyna, her team, you can definitely get in touch with them directly, or you can email me. I have put my email address in the chat. I will be more than happy to forward any of your questions to Dr. Khrystyna and her team at Alternatyva Clinic. Thanks again. And
thank you very much.
I hope to see you here quite soon as well. Take
Have
care.
a nice evening, everyone. Bye.
Bye.